You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 22nd, 2023. Our topic is Anaphylaxis and the Practice Parameter, presented by Dr. J. Lieberman. He is a professor at the University of Tennessee in Lieberman Children's Hospital, chair of the Food Allergy Committee for the American College of Allergy, Asthma, and Immunology, and is the co-chair of the Joint Task Force for Practice Parameters. You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 22nd, 2023. Our topic today is Anaphylaxis and the Practice Parameter, presented by Dr. J. Lieberman. He completed his residency in internal medicine at Washington University in St. Louis, Missouri, and then his fellowship in allergy and immunology at Mount Sinai Hospital in New York City. He is currently a professor at the University of Tennessee in Lieberman Children's Hospital. In addition, he serves as chair of the Food Allergy Committee for the American College of Allergy, Asthma, and Immunology, as co-chair of the Joint Task Force for Practice Parameters, as an associated editor for the Annals of Allergy, Asthma, and Immunology, and as a board member for the ABAI. Thanks for being with us today.
Thank you very much. Unfortunately, you got the wrong Lieberman to present this anaphylaxis and the practice parameter, because Senior Lieberman has been doing these practice parameters for the last probably 20 years. But unfortunately, you have to deal with me as he's passed on the torch. And so what I'm going to do in the next 40 or 45 minutes is I'm going to run through the latest practice parameter. This practice parameter is just about to be published. It's already gone through the review. It's now just going through the editorial. So it will be published online within the coming month or two, is my hope. So you'll kind of see all the recommendations from that. Before I go into the practice parameter, I know this is, mostly fellows who watch this. So I don't know if fellows are aware of what the practice parameters are. I'm just going to send 2 quick slides. The practice parameters are just an appointed group from the college and the academy. So 6 representatives from the college, 6 representatives appointed through the academy to make a 12-member group. And what we do on the Joint Task Force is together decide which topics to do for the practice parameters. And then once we get a topic selected that's approved by the academy and the college, we select a work group chairperson and a JTF liaison, who then will recommend work group members. We get the work group members approved by the academy and the college, and then they start doing the draft. The document usually takes at least a year or two to actually go through the full, writing, review, and then we review it, as well as there's a public review. So if you are a member of the academy or college, you have the opportunity as a public member to review and give feedback on the guideline before it ever goes for publishing. So you'll get those emails through the college and the academy. So the anaphylaxis practice parameters have been going on for a long time. So this is just one of the updates back in 2005. And they have been updated pretty much every 5 years. Here's the 2010 update, 2015 update. And then in 2020, we changed up a little bit how we did it, and we did what's called a grade update. And this had very specific questions. So a grade practice parameter, a grade guideline, really is different than the traditional practice parameter. The traditional practice parameter is the experts do the review. It's their expert opinion. They come up with consensus and give the recommendation, whereas a grade guideline requires much more rigor, systematic review, really applies much more data into the strength of the recommendation in a very systematic way. It also usually will include patient partners or patient advocates to get their input on the recommendations. So it's a little bit different than our traditional guidelines. So that one was published in 2020, and now this update will go out, and it's a 2023 update. Will probably be published in 2024. And so it'll be a little dry. I'm going to go through the guideline. And I'm really going to go through mainly the updates, but what I'm going to do is give each recommendation in the document. It's a pretty big document. I'm gonna give you each recommendation so that you're aware of them, and then we'll hopefully have some time for questions. All right, so the first part of the document goes over anaphylaxis definition and diagnosis, and gives some updates in that realm. And so just to go back a little bit, is, definition of anaphylaxis is very, very hard. The term was coined over a century ago when Richet and Portier were trying to find essentially antitoxin. So trying to find antitoxin for the Portuguese man-o'-war, or essentially jellyfish. And in doing so, what they found is that they gave the toxin to dogs and then re-exposed the dog when they thought they were going to get an antitoxin or antibody. They actually invoked a more severe reaction after the first exposure. And so they essentially just made up a term called anaphylaxis, which would have been the opposite of prophylaxis. And so that's where the name came from. And over the last 125, 150 years, it's been kind of altered, and we still don't have an actual good a good definition of anaphylaxis. What I've put up here is some various groups' definitions over the last 20 years or so. So you have the NIAID definition, the practice parameters, World Allergy Organization, the European Allergy, and then the Brighton group, which does more for vaccine reactions. But what you can see is they each have a different definition. And so that starts us out with a really big problem. As you are trying to figure out that one definition, you're not going to find one. So what the NIAID did, 20 years ago or so, back in 2006, is they, instead of trying to find that one definition, they really tried to get experts to agree on a clinical definition, meaning, well, forget the words. When should we give epi is really what they were trying to discover. What is a scenario in which anaphylaxis is highly likely and therefore epinephrine should be given? And then this clinical definition has since been used as kind of the definition for research studies. How do I know if a patient's having anaphylaxis? Well, we use the Sampson criteria or the NIAID criteria. That's what this is. So hopefully as a fellow, you've seen this criteria. This is kind of the gold standard at this point. And what you can see is it's not perfect. It says anaphylaxis is highly likely when any one of these three following scenarios. Some of the angst with this is something, it's not very specific. So for example, in criteria 2 under D, it says persistent gastrointestinal symptoms, abdominal pain. Well, abdominal pain is not that uncommon. So if you just have some abdominal pain for an hour in hives, that technically may meet this criteria. So it's not perfect, but it has been validated in retrospective and prospective studies. So this is kind of the gold standard, if you're a fellow, of how to define anaphylaxis. The World Allergy Organization tweaked that a few years later, and they had it simplified. So they said anaphylaxis is highly likely when any one of the following two criteria. So they minimized it. They took away a third. And now it's just these two criteria: acute onset of an illness with involvement of skin mucosa, or one of the following: respiratory, reduced blood pressure. And then they changed it to severe instead of persistent gastrointestinal symptoms, such as severe crampy abdominal pain, which you can imagine is not perfect either. What constitutes severe crampy abdominal pain? Because we don't have a definition for that. So it's not perfect. But they modified it just a little bit, and you'll see that definition out there as well. A few years ago, Tim Dribbin and colleagues published this, which attempt to define anaphylaxis subsets. Once again, this is just expert panel getting together and trying to decide this. But they define persistent anaphylaxis is when you meet anaphylaxis criteria and it's going on for at least 4 hours. Refractory anaphylaxis is when you meet two criteria: the presence of anaphylaxis following epinephrine administration, and then they go on to say the initial reaction has been treated with 3 or more EPIs. So that's refractory by this definition. And then they try to define biphasic, which they say is likely when you have all four of the following criteria: newer recurrent symptoms that fulfill anaphylaxis, initial symptoms have completely resolved, you have absence of re-exposure to the trigger, and then it occurs 1 to 48 hours after complete resolution. So this is in the new anaphylaxis practice parameters. It doesn't mean it's the end all be all, but it gives you some framework at least for how to define these criteria. So when we're trying to diagnose anaphylaxis, it's all well and good. We understand that this is a clinical diagnosis, but we would like some objective marker. And in the past iterations of the practice parameter, it did talk about histamine and tryptase. And in this iteration of the practice parameter, you'll see that it mainly concentrates on tryptase. Since the publication of the past practice parameters on anaphylaxis, the update now is in how we define a elevation of tryptase. So in the past, years and years ago, you saw a patient acutely get a tryptase. If it's elevated, great. If it's not, it's probably not anaphylaxis. And that's been modified over time. And what we now have is a change in anaphylaxis over the baseline. And there's two scenarios you can use, right? So the first scenario is the 20+2 rule. So that's one calculation you can use. That says you get a baseline tryptase either before or after the event, and you get a tryptase during the event. And the tryptase during the event, if it goes up by 20% over the baseline plus 2 nanograms per ml, that is significant and suggestive of mast cell activation. And that's been validated in perioperative anaphylaxis with sensitivity and specificity there. So it's by no means perfect, but it does give you something to use when you're trying to decide if a change in tryptase is significant or clinically meaningful. The other calculation that you can use is established by the NIH. And what they've done is used various cohorts of patients with anaphylaxis, mast cell disease, et cetera, and their calculation that they have, and you can have this little calculator online through the NIH, is the ratio of 1.685 above the baseline tryptase, and that is what clinically is significant in their patient population. So our parameter doesn't say you should use one or the other, but either of these. And the more common one you'll see is the 20% plus 2. You'll see that more in the literature, just because the other one's newer and it hasn't been validated as much with other cohorts. When diagnosing anaphylaxis, obviously the differential is very, very important. This differential is listed in the new parameter. It is not much different than the differentials in the past parameters. I mean, the obvious ones are when you have, known allergens, foods, insect sting, drug, etc. Physical stimuli, obviously less common, but on there. And then, food-dependent exercise-induced or idiopathic. The others are mast cell activation syndromes, whether clonal or not, or genetic predispositions such as hereditary alpha-tryptocemia. Obviously, these patients are more prone to anaphylaxis than patients without a mast cell disease. They still get anaphylaxis, but it's obviously different, and the triggers may not always be there. And then the other non-mast cell things, or at least non-provoked things like vasovagal reactions, flushing syndromes. And for me, the very important group is the non-organic causes. I think this came to light a lot in a lot of the literature and in the lay media, especially with COVID vaccinations, in which you were having all these reports of anaphylaxis, some of which did meet Brighton criteria, but when you really looked at them, many of those probably constituted a non-organic cause. So it's always important to think about that, and that's where the tryptase hopefully can help you out. So now we'll go into the diagnosis recommendation. So you'll see this CBS, and it just numbers them throughout the document. That's a consensus-based statement. That's the terms we use for a traditional practice parameter. And then we always give the strength of recommendation, and then the evidence, the certainty of evidence. Remember, the strength of recommendation can be strong even though the evidence is moderate or weak. And that's based on the risk of, the risk to benefit to harm ratio is probably still beneficial, even though the evidence is weak. And that's classic for something like giving epinephrine, where we have weak evidence, but a strong recommendation. So the recommendations in the diagnosis section are that we recommend obtaining a baseline tryptase in patients presenting with a history of recurrent idiopathic or severe anaphylaxis, particularly those presenting with hypotension. And we suggest drawing an acute tryptase level as early as possible during an anaphylactic event. It doesn't have to be exactly 1 or 2 hours, anytime, ideally within the first 2 hours. And then you get the baseline tryptase if they're coming into your clinic, when they're otherwise normal, to get the comparison. There's this diagnostic kind of algorithm in various publications, and we kind of altered it just a little bit for our publication. And what you see, this is very important for allergists who are, working in practice all the time, is the patient presents to you after the event, and then you've got to decide what to do and how to work them up. Well, when the trigger is obvious, that's very obvious. We do our skin testing or our serum IgE testing. We consider, if it's positive, we consider putting them on immunotherapy for venom, maybe even for oral immunotherapy or something like that for food. But you're considering treating that, and you've got your answer. When the skin testing is negative, if it's clearly anaphylaxis, that becomes a little bit different. So we always say consider epinephrine autoinjector, a patient diary, and then getting that prescription for a tryptase at a future event, so that if it happens again and they're in the ED, they can get a tryptase to know if it's actually changed. When the trigger is not identifiable, so idiopathic anaphylaxis, we do recommend getting that baseline serum tryptase and then giving them the prescription for it during an event. If the baseline tryptase is elevated, then you need to think about a clonal mast cell disease, and we'll talk about how to do that later. And if it's less than the 11 cutoff but higher than 8, you can also consider hereditary alpha tryptopenia. If the baseline tryptase is not elevated, consider looking at the REMA score, which we'll go over in a little bit, and that's a score to evaluate for possible clonal mast cell disease in a patient presenting with idiopathic anaphylaxis. If the REMA score is high, again, consider evaluation for mastocytosis. The tryptase is not elevated, the REMA score is not high, then you really need that repeat tryptase during an event, if it happens again, to know if this is truly a mast cell activation disease. If the tryptase is not elevated during an event, that's where you go through your differential, and including the non-organic causes. But if the tryptase is elevated during the event, then consider mast cell activation syndrome, alpha-gal, or if you found the trigger at that point, then you'll know. So alpha-gal and hereditary alpha tryptopenia are new from the prior iterations of the parameters. I'm not going to go in depth, but obviously you need to think about these in patients who present with especially recurrent symptoms of anaphylaxis when the trigger is not clear. Okay. The other things we put in here is that we're trying to get away from this idea that epi equals anaphylaxis. So you can give epi even if it's not anaphylaxis, and people give epi. You shouldn't use epi as a marker that that patient had anaphylaxis. So the recommendations here suggest that meeting diagnostic criteria for anaphylaxis is not required in order to use epi, and don't use epi if someone got epi as a surrogate marker to establish a diagnosis of anaphylaxis. So you really need to delve into the history before you just say, oh, that patient had anaphylaxis because someone gave them epi. Okay. The next section in the parameter that's new from prior iterations is anaphylaxis in infants and toddlers. And obviously this has come up to light more in the past few years because of early introduction of foods. And it's important because infants have unique characteristics. They can't tell you their symptoms. They may have different symptoms of anaphylaxis. They're smaller, and that may matter with what type of epinephrine they get. The dosing of epinephrine obviously is important because they're so much smaller. So what are the recommendations here? So number one, there are no guidelines for specific diagnosis in infants. So we recommend using the current diagnostic criteria, whether NIAID or WOW criteria, in infants and toddlers. Be aware that age, infant and toddlers' age is not correlated with reaction severity. And even more important, below that, clinicians be aware that anaphylaxis is unlikely to be the initial reaction to a food or medication upon first exposure. and this is really important with early introduction. Most of this data come out of really good studies out of Australia, where incidence of anaphylaxis in early introduction without screening is very, very low, even if they have a reaction. The next recommendations, we suggest clinicians be aware that parents of infants and toddlers may report age-specific symptoms, which we talked about, that we don't see in older results, such as fussiness, pulling at the ear, things like that may be indications of an allergic reaction. And then importantly, we suggest that clinicians prescribe either the 0.1 or the 0.15 milligram epinephrine autoinjector. I routinely prescribe the 0.15 even in the 6-month-olds. The data on bone penetration of the needle or overdosing epinephrine is very, very scant and really non-existent. So there's nothing wrong with giving a 0.15 to an infant, even if they're very small or don't quite weigh the 15 kilos or even 10 kilos for that matter. All right, the next section that's new in this practice parameter iteration is anaphylaxis in the community. So just a quick information before the recommendations. So just realize that the majority of reactions, whether you're an adult or child, happen at home. Most parents are always nervous, obviously, of sending the kid to school or eating at a restaurant. But if you look at large data sets, the most common place of reaction is still at home. The younger they are, the more likely that is to occur at home. And then when they get adolescents and older, it starts getting more common in other places, but still home is the most common. So recommendations from the anaphylaxis in the community section. We recommend clinicians counsel patients at high risk of anaphylaxis to always carry epinephrine. This is not new. And in addition, teach your patients how to use it. Nothing new there. We recommend clinicians educate patients on avoidance of potential triggers. Nothing new there. We recommend clinicians educate patients that the main route of food-induced anaphylaxis is by ingestion, not contact or inhalation. This came about because there's a lot of concern, sitting at a table with somebody, et cetera, will lead to anaphylaxis. And we're trying to kind of dispel that concern or myth with that recommendation. The other one is with jewelry. So we actually recommend that it's optional. So we suggest that advising individuals at risk for anaphylaxis to wear or carry medical identification be considered optional. It is not required. Anecdotally, I don't have any of my patients do it, but if they wear it or carry it, make sure the wording is correct. And I would recommend you as the clinician, if they're wearing it, take a look and make sure it's justified and warranted. The next recommendation is that keeping stock epinephrine in community settings should be encouraged wherever feasible. There's good data that stock epinephrine can be very cost efficient and work just as well as everyone having their own. Next one, in school and child care centers, we suggest child care centers and schools implement staff training. There's a little bit of evidence that training can improve reaction severity, or rather response to reactions. But we do have some other, not controversial, but newer recommendations. So we suggest child care centers and schools not implement site-wide food-specific prohibition. Data suggests that this does not offer any benefit, meaning the peanut-free table, you now have a recommendation that says we don't recommend doing that. Now, it might be appropriate in where students lack the capacity to self-manage. So that's in very, very young age, maybe in daycares or something like that, where you can't trust the kid to put something in their mouth. But overall, we recommend not using food bans. And then we suggest child care centers and schools stock undesignated epi, so the stock epi thing comes up there as well. Okay. Next section, epinephrine autoinjectors. All right, so we suggest clinicians routinely prescribe epinephrine autoinjectors to patients at higher risk of anaphylaxis. When deciding whether to prescribe for lower risk, we suggest that clinicians engage in a shared decision making. So this is very different, right? And so it's not saying every single person that walks through your door with possible anaphylaxis should get epinephrine. And so a lot of these recommendations you'll see are trying to incorporate some shared decision making in this process. So there's a table in this one of kind of saying maybe who should get epinephrine and who shouldn't, right? With IgE-mediated food allergy, it's a little harder. I mean, obviously, if they've had a systemic allergic reaction, but we don't have good data on who's, lower likelihood of anaphylaxis. There's a lot of work being done in that, so trying to risk stratify food allergic patients beyond just your non-pollen food syndrome, your IgE-mediated, you need an epinephrine autoinjector. For now, we don't have that, but hopefully we will one day. For pollen food syndrome, obviously, they've never had anaphylaxis to it, they're lower likelihood, maybe you don't provide them an epinephrine autoinjector. We give some, for other things, we give you when you might want to do it, when you might want to prescribe it based on higher likelihood of anaphylaxis. And there's also the guidance on allergy immunotherapy down there of when to give patients allergy immunotherapy. A lot of practices obviously will give every patient a epinephrine autoinjector who are on allergy shots, although we try to allow you some room there to say who really needs it. And then here is the risk factors and cofactors for severe or fatal anaphylaxis. It's different by the trigger, and so you can try to incorporate this in your shared decision making when you're saying, would this patient benefit from an epinephrine autoinjector? The other thing that's new here is we're trying to get away from everyone has to have two, right? That's kind of a dogma that's been really hammered over the years into us. And it says in our recommendation here, it says we suggest that in jurisdictions where single packs of EAIs are available, clinicians consider a patient's risk factor for severe anaphylaxis and their values of whether to prescribe more than one. Obviously, and just anecdotally, if a parent comes in saying, I want 3 2-packs, I'll prescribe it, and I'll have the conversation of, how many do you really need? But it's this idea that everyone has to have 2 based on really poor data that's needed, just because, they've come in a 2-pack now because that's how they're packaged and manufactured in the US. I don't think this will change anything. I think all of our patients will still in the US all have a 2-pack for a long time, but at least it's in there in the guidelines now for you. So anecdotally, I also will tell patients, it's okay if you want to get a 2-pack, send 1 to school and then keep 1 with you. I'm fine with that if, in a shared decision-making context. Optimal timing for EAI, there's 2 recommendations here. We suggest that clinicians counsel patients, caregivers to give epi the first sign. Obviously, if it's true anaphylaxis, earlier the better, we think at least. And then we also put in there, we suggest that that in general, clinicians counsel patients or caregivers not to give epinephrine preemptively to an asymptomatic patient, right? And that's kind of on some of those emergency action plans. They'll say treat even if suspected ingestion, even without signs or symptoms. We would typically steer away from that. Once again, shared decision making would be appropriate there. This is really new in the practice parameter. I'll spend a minute on this. Obviously, in every emergency action plan currently, it says if you give epi, call 911 or seek emergency medical care or something like that. And we're starting to try to get away from that a little bit, right? So these recommendations say we suggest that clinicians counsel patients that immediate activation of EMS may not be required if the patient experiences prompt, complete, and durable response to the treatment with epinephrine, provided that additional epinephrine and medical care are available if needed. And it says we suggest that clinicians counsel patients to always activate EMS, however, following epi use if anaphylaxis is severe and fails to resolve promptly. We're trying to give clinicians and patients an out to say you don't always have to go to the EMS or go to the hospital just because you use epi. And this is obviously prompted by COVID, in which you had the risk may have been worse to go to a emergency room during the peak of COVID than it would have been just to say, I gave myself epi, I'm feeling better, I'm not going to go, right? So that's kind of what prompted this. And so in this, there was also a expert opinion piece in practice a few years ago that talked about when might it be okay to stay home, when might it be okay to go to the emergency room. There's some of this discussed in the practice parameter. In the practice parameter, we did not provide a new emergency action plan that says this. My hope is that there will be something in the near future that's kind of accepted that says you don't have to call 911 if you give yourself epi, because all of them essentially say that right now. But essentially, it's kind of common sense. If you give yourself epi, everything's completely resolved. You're feeling fine. You can watch that kid or patient at home if they're okay with it, with close observation, as long as there's an epi available for a biphasic reaction for another dose somewhere in the home. So that at least gives clinicians a little bit of leeway, and if they do counsel patients that there's something in guidelines now that says you don't absolutely have to do that. We also put in there some things about whether or not to prescribe it in that shared decision-making capacity. Think about financial and psychosocial burdens of epinephrine auto-injectors when prescribing them. When deciding which emergency epinephrine auto-injector to prescribe, we suggest that clinicians consider dosage, needle length, affordability, access, and all that. We're not going to tell you what to prescribe or on who. We do give a table with those available in the US, Canada, and most of Europe. Obviously, not all of these are available in the US. I'm not going to go into it, but it'll be in there with needle lengths and dosages available. As far as counseling and education, if you're going to prescribe it, there's a recommendation that you routinely review carriage, storage, use, how to use it, practice, and discuss when to use it with your patients. All right. Next section went into beta blockers and ACE inhibitors because there's a little bit of update there. And this once again goes to the shared decision making, right? And so the recommendations here, we suggest patients with a history of insect sting anaphylaxis who are not receiving immunotherapy should continue beta blocker or ACE inhibitor when it's medically necessary. It's really shared decision making benefits risk. That patient probably is better off being on a beta blocker or ACE inhibitor for their long-term health than taking it off in most cases. There's also some comments of, use a cardioselective beta blocker when possible. The consensus-based statement number 32, we suggest venom immunotherapy may be prescribed for patients with a history of insect sting anaphylaxis who are treated with a beta blocker ACE inhibitor with shared decision making once again. And then those on maintenance in the next one should continue it. So treatment with beta blocker or ACE inhibitor should not be changed or discontinued in patients receiving maintenance. But if you're talking about starting someone on venom immunotherapy who's on a beta blocker, you need to have that discussion. And if it's for venom, it's probably reasonable to continue it, but you guys discuss the risks and benefits with that patient. With allergy immunotherapy non-venom, that's a different story because that is not a life-threatening condition, right? That's a quality of life condition. So the recommendation is different. Here, we suggest use of initial allergy immunotherapy may be considered in patients who are treated with beta blocker ACE inhibitor with shared decision making. But it says here it would be preferable to replace the beta blocker ACE inhibitor if there is an alternative. So because this is not life-saving, if you really want to put that patient on allergy immunotherapy, you should try to find an alternative. And then the next one is we suggest patients receiving maintenance dose immunotherapy, however, have minimal increased risk of severe anaphylactic reaction when on the beta blocker ACE inhibitor and may consider continuing it. So if you're on maintenance, just continue it. But if you are going to build someone up who's on a beta blocker and ACE inhibitor, you can do it, shared decision making, but it says you should probably try to find an alternative if you're going to do that. And then there was a couple other ones kind of that didn't really fit so well in there, but talk about beta blocker and ACE inhibitor. So when you're doing a planned procedure, such as a challenge or desensitization or infusion, if the beta blocker and ACE inhibitor can be safely interrupted, it's probably better to do that, right? So short-term interruption of beta blocker ACE inhibitor is probably reasonable for most patients, but it needs to be discussed and understand why they're on the medicine before you do that. And then the unknown exposures, we suggest that all patients at significant risk for recurrent unexpected anaphylaxis. So if you have a mastocytosis patient, recurrent idiopathic anaphylaxis, we really recommend avoiding it where possible and using cardioselective beta blockers at least. Okay, the next section, obviously this is not a mast cell disorder parameter, but you can't talk about anaphylaxis without at least discussing mast cell disorders. So there is a section on mast cell disorders and anaphylaxis. Once again, here's the World Health Organization, criteria for systemic mastocytosis. So it's in there if you need it. But regarding recommendations with mast cell disorders and anaphylaxis, we tell you, obviously order a bone marrow biopsy staining for tryptase CD25 by immunohistochemistry as well as flow cytometry, and get the D816V mutation whenever possible if you have suspicion for this in your workup for anaphylaxis. And don't rely on a serum tryptase level because it can be normal in a clonal mast cell disorder. Once again, it's the baseline serum tryptase, especially in patients who had hypotension or absence of urticaria, and that's based on the REMA score, which we'll go over in a second. And then we suggest clinicians consider evaluation for masto, including bone marrow biopsy for adults who have severe insect sting anaphylaxis or recurrent idiopathic anaphylaxis. So the REMA score is based out of Spain, where they looked at idiopathic anaphylaxis patients being referred for possible clonal mast cell disease. And what you can see are, if you have characteristics in this cohort that were suggestive of clonal mast cell disorder, male gender, absence of urticaria, if you had syncope, or if your tryptase is greater than 25, essentially all those are risk factors in a cohort of patients with idiopathic anaphylaxis, risk factors for clonal mast cell disorder. So if your score on the REMA score is greater than or equal to 2, that would be something to push you to try to get that patient a bone marrow biopsy. So when you're doing the workup for idiopathic anaphylaxis, you want to think about this score in the back of your head. Even if the tryptase is normal, consider this when deciding who gets a bone marrow biopsy. And then it says, we suggest venom immunotherapy be continued indefinitely in patients with mastocytosis and insect sting anaphylaxis. This isn't much new, but it's in there as one of the recommendations still. All right, last section is the perioperative anaphylaxis section. And the recommendations here are, we suggest immediate hypersensitivity skin testing or specific IgE testing when available to all potentially pharmacologic and non-pharmacologic culprits. And then we put in there, we suggest referral to a center who can do this if you cannot. So this always gets a lot of consternation, because when you're evaluating perioperative anaphylaxis, yes, neuromuscular blocking agents and antibiotics are the two most common triggers, but they definitely don't capture everything. So in a perfect world, you would have that patient tested to every single thing they were exposed to. We understand this is almost impossible in private practice settings. And so we recommend doing it. And if you can't do it, hopefully referral to a center that can. It's not always easy. Some centers may not even be, some academic centers may not even be able to do it. But we hope is that this is probably the best practice if you can do it. We also recommend that the skin testing be delayed until after the event. If surgery with general anesthesia cannot be postponed, you could do testing immediately or right after, but we ideally recommend waiting, usually 4 to 6 weeks after if possible. If you can't do that because urgent surgery is needed, go ahead and do it sooner. And then we do suggest challenges be performed whenever feasible. If you can work with your anesthesiologist and say, while they're under, if they could get this, based on the testing, that would be the most ideal. That, once again, we understand that's very, very hard. Most people don't have that relationship, or the anesthesiologist won't, care or listen. But whenever possible, probably best practice. Obviously, not going to go in this. Just to let you know, this will be in the new published guidelines. We'll give you, and you can find this in other resources as well. But these are the concentrations for skin testing and intradermal testing to the common agents. So repeat anesthesia. We suggest the repeat anesthesia may proceed in the context of shared decision making based on your test. That's obvious. Avoidance of culprit agents where we have positive test results if challenge is not feasible. So if you can do a challenge even with a positive test result, consider it. But obviously, if you have a positive test, no one's going to want to challenge it. No problem. Challenge to the other things. And then no recommendation on whether or not to use any kind of pre-treatment for the future when they get the next surgery. But typically, in a perfect world, you'll have your positive testing, use everything else, is what it's saying. Okay, I'm going to close out there because I do want to leave time for questions. But here are the take-home points and some of the new things. We don't have a single definition. Use the NIAID or the World Allergy Organization clinical definition. Please use serum tryptase. Get your baseline when they come see you in clinic after the event, and then ideally get a tryptase during the event to really understand if we think this is mast cell activation. In infants and toddlers, they can present differently, but use the same criteria and use any form of epinephrine. Do not be afraid to use 0.15 in a 6-month-old. With epinephrine scripts and use of emergency medical services after use of epinephrine, there's a shift towards shared decision making. So the parameters will give you a little more leeway in doing these things, such as maybe not giving every single food allergy patient an epi script, maybe not having every patient go to the emergency room or call 911 after they use epi for maybe even a minor reaction and they're better. Using shared decision making with beta blocker and ACE inhibitor. If it's for allergy immunotherapy that's non-venom, probably don't start them unless you've had that shared decision making discussion and tried to get them an alternative. But if they're on maintenance, continue it. After perioperative anaphylaxis, try to test for all possible culprits a few weeks after, whenever possible. So those, I think, are the major take-home points.